Hi, I'm Dr. Robert Cato of General Internal Medicine, and today we're going to go through a targeted musculoskeletal examination for all of the key joints. This is Alex Bunnell. He is one of our medical residents, and he has graciously offered to be the model for today. With each joint, we'll be going through a regular pattern of starting on inspection, going to touching some key anatomic landmarks, and then we will be doing movement, and some extra maneuvers to try to bring out some of the abnormalities that may exist in that particular joint region. We'll start with the hands. Just hold out your hands like this, please, sir. Okay, turn your hands this way, please. Okay, and just like that. And I'm going to resist. Don't let me pull it through. Good. Same thing over here. Okay, and spread your fingers as far apart as you can. Don't let me push them together. Okay, excellent. Okay, pull your thumb back like that for me, please. Pushing in the anatomic snuff box, feeling the navicular bone or the scaphoid bone. Okay, just hold your wrist like this for me, and then all the way up, and then back down straight, and then out this way, and then out this way. Excellent. Now hold your hands like this for me. This is the Tinel sign, looking for carpal tunnel syndrome. And now put your hands like this for me, please, and hold it like that for 30 seconds. This is the Phelan sign. A positive sign would be numbness or tingling in one of his hands, suggesting carpal tunnel syndrome. Okay, you can relax there. Just show me both of your elbows like this, please. Inspecting. Palpating the olecranon process. Palpating the medial epicondyle. And palpating the lateral epicondyle. Asking the patient if any of these things are hurting him. Okay, just bend your elbow back all the way, please, and then extend it all the way. Okay, good. Now, hold your arm out like this for me. Now try to raise your wrist against me, and now push down. These are tests for lateral epicondylitis and medial epicondylitis, seeing if that provokes pain up in the epicondyles, suggesting a tendinopathy. Okay. Palpating along the clavicle, up towards the acromioclavicular or AC joint. All of these palpations, I'm asking if we're causing pain. Palpating on his acromion and the subacromial space. Now with my fingers, palpating the biceps tendon. Okay, so now I want you to just do what I'm doing. I want you to raise your arms above your head as high as you can and relax there. Good. Now hold your hands on your side and then open as wide as you can. Keep going, keep going, keep going. Looking for range of motion. Good, you can relax. Now put your hands behind your back as high as you can. Looking for symmetry and range of motion, which is normal. Excellent. Now with this right arm, I'd like you to hold your arm out like this for me. And I'm going to push down. Don't let me push. Keep it up, keep it up, keep it up. Okay, good. Now with both arms, hold your arms at your side. And when I tell you to, try to open, but I'm going to resist you. And out. Good. These resisted motions are to try to provoke pain in people that have muscle or tendon problems. And when they have pain there, it suggests that's the problem as opposed to the joint space itself. Okay? With the right arm, just put it behind your back again. And then push off as hard as you can against me. That's another test that we can do for one of the rotator cuff muscles, the subscapularis. Okay. Now I'm going to grab a chair, and I'm going to examine the knees. So first I'm inspecting, and then I will examine the right knee. I will palpate along the quadriceps tendon to where it inserts on the patella, trying to provoke pain. I will then palpate along the inferior border of the patella, along the patellar tendon or patellar ligament. I will now find the medial joint line, which you'll notice is more anteromedial than medial, and push firmly. And then I will find the lateral joint line, again pushing firmly in the lateral joint line, which is anterolateral, not very lateral. Okay. I will now palpate very medially, which is the location here of the medial collateral ligament, or the MCL, trying to provoke pain if he has pain there. Now we'll switch over to the lateral aspect of his knee, palpating first over the fibular head, where one of the hamstring muscles inserts, and then further up, where the lateral collateral ligament would be, looking for pain there. And then finally, I would palpate laterally above the knee, along the iliotibial band, the IT band, again asking if that's causing any pain. Okay, good. Finally, I will palpate a couple of finger breadths below the medial joint line in this region, which is the site of the anserine bursa. Tenderness here would suggest anserine bursitis. Okay, excellent. Would you lie down, please? Okay. Now I will assess his knee for warmth. Comparing the two sides, typically the patella is a little cooler than the rest of the leg. I will move the patella around, trying to provoke pain. Now I will assess movement of the knee. Just bend this back for me. Flexion, which is full, and extension, locking the knee. And I'll do that a couple of times, feeling with my other hand for any crepitus or other abnormalities, and seeing if that provokes pain. I will now ask him to bend his knee back and to try to straighten his knee. Go ahead, straighten the knee. That would test for quadriceps tendinopathy. And now try to bend the knee, which will test for hamstrings tendinopathy. Again, resisted isometric activity tests muscles and tendons. Excellent. Now what I'll do is examine the hip. With the hip, there's not much inspection because the hip joint is very deep in there. There are a couple of places to touch. And first we're going to palpate in the groin region, which one important point is to remember that the hip joint is in the groin region. The anterior is not laterally. So palpating there just for any masses or lymph nodes that might cause groin pain, but you cannot palpate the hip joint itself because it's too deeply embedded inside. So other palpation would be for him to roll onto your side facing that way and feeling laterally in the hip over the greater trochanter of the hip, which is here, which is the insertion of the gluteus muscles, which can be painful in people with gluteus medius tendinopathy or greater trochanteric bursitis. So again, it's lateral. This is not the joint though. You can lie back on your back again. And then for the hip, we're going to assess the range of motion of the hip, first with flexion, bringing him up, full flexion. And now with internal rotation, noting that his internal rotation is at least 45 degrees of internal rotation. This is the most sensitive finding for hip joint problems. And then external rotation as well. So he has normal rotation there and flexion. And now I'll test the hip flexors by doing isometric activity, asking him to try to lift his leg straight up against me. Lift it, keep going straight, don't let me push it down. Good. And that's a hip flexion test, seeing if that provokes any pain in the muscles and tendons of the hip flexors. Okay, you can sit up again. And that's the end.